neuroma occurring here, or a temporal bone fracture. That'll usually involve the whole facial nerve. But if you think about an injury to the face, like a stab wound, gunshot wound, a salivary gland tumor out here, then you might just get an injury to some of these branches. And so you take a different approach depending on which branches are affected. So we have a mnemonic. I don't know if you learned the same thing in medical school as the same mnemonic as we learned. We learn, and thank you to Africa, because Zanzibar is in Africa. I realized that it's on the east coast of Africa. To Zanzibar by motor car. So T for temporal, Z or Z for zygomatic, B for buccal, M for mandibular, and C for cervical. So these are the 5 major branches that come out here to supply the facial nerve. And honestly, most of us who do EMG don't remember every single muscle in the face and where it is and what supplies it. But it's good to remember some representative muscles from each of the major branches. So your temporal branch, now remember, it doesn't supply temporalis, because temporalis is a muscle of mastication, and that's supplied by all the muscles of mastication are supplied by the 3rd branch of the trigeminal nerve, or V3. But so it doesn't supply temporalis, but it does supply frontalis, orbicularis oculi, and your corrugator muscles right up top here. And then you have your zygomatic branches, which innervates the orbicularis oculi, right over here, as an example. Your buccal or buccal branches, they innervate part of the orbicularis oris, not the whole thing, but also your buccinator, your zygomaticus, which raises the lip here, is the buccal. And then marginal mandibular or mandibular branch, that comes out down here. It supplies the mentalis muscle, also supplies this little guy right here, the depressor anguli oris, which depresses the mouth. Now this branch can be selectively affected, and we'll show you a case a little bit later, by, say, operation for a submandibular salivary gland tumor, and you can just get that branch. And then you have the cervical branch, which supplies the platysma muscle down here, platysma muscle. You also have a little occipital branch that supplies the occipitalis and also the auricular muscles that move your ears, but those aren't commonly studied. So what are some of the common causes of facial neuropathy? Well, there are a number of different possible causes. So probably the most common one that we see is Bell's palsy or Bell palsy. And that's an idiopathic swelling of the facial nerve within the bony canal of the face, of the temporal bone. We usually think of it's possibly due to some viral infection or some autoimmune reaction that is secondary to a viral infection. But it's a swelling around the nerve within the facial canal. Most people do well, but there is a small subset that don't get a good recovery after a Bell's palsy. You may wonder, how come I don't have apostrophe S here? The technically correct way to talk about this is if Bell was the person who actually had the disease himself, then it would be Bell's palsy with an apostrophe S. But if he named it, then it's technically called Bell palsy. Another one that we see not too uncommonly, particularly if you work in a trauma center, is temporal bone fractures. Because that facial nerve travels right through the temporal bone, a temporal bone fracture can cause a facial neuropathy. If you see much in the way of tumor resections, if you have a busy neurosurgical service, then either the acoustic neuroma by itself can press on the facial nerve, or it may be that you resect the acoustic neuroma, and at the time of the resection, you cause some impairment of the facial nerve. So either of these can be a cause. And then trauma to the face. So this is, now, when you're out at the trauma, then you can affect some branches and spare others. So for instance, if you're just recording from nasalis, when you're doing your studies. You wouldn't pick up an injury to other branches, say the marginal mandibular branch or the some of the lower branches. So what is the role of electrodiagnosis? What's our function in evaluating someone with facial neuropathy? Well, really, as usual, it's diagnosis and localization. And then also we add some for prognostication. So diagnosis and localization. Usually the diagnosis is pretty apparent based on your clinical presentation. You can tell whether it's upper or a lower motor neuron. You can get a sense of whether it's Bell's palsy or trauma. The one exception for detecting facial neuropathy is in comatose patients. So this happens when you have a patient with a severe temporal bone fracture. They're comatose. You can't really assess their facial nerve very well. And in some of these cases, you do want to do the nerve conductions to see if you should decompress the nerve. The surgeons believe that the timing of decompression is best done around 7 to 10 days after injury. Now, we can't really assess them too early because we don't have all area degeneration yet. So our timing is probably best within around that 7-day mark after injury. That's probably the best timing to assess it. And as I mentioned, they do believe that early exploration and decompression can be helpful. And then prognosis is the other part that we play a role, and this might even be a bigger role than the diagnosis and the localization, is establishing the prognosis for recovery. And in general, with facial nerve, as with any other of the peripheral nerves, the more axons you've lost, the worse the outcome. And that, of course, makes sense. The more you've lost, the worse the outcome will be. And there is one difference, though, with facial nerve as compared to peripheral nerves. So in peripheral nerves, the main thing that you note with a lot of axon loss is weakness of the limb. You just can't contract the muscle. You can't produce much force. And that's the main deficit. In the facial nerve, we also have the issue of synkinesis. So, and this doesn't happen so much in the limb, but it does happen in the face. So if you have a lot of axon loss, and you have regrowth, the axons may regrow down the wrong neural tubes that they weren't intended for originally. So that then when you close your eye, your mouth moves, or vice versa. And so this cross innervation can be a problem for patients cosmetically. When do we want to do the studies? I think we want to think about the timing carefully. So if you do it within the first 7 days, then you may have studied the person too early before Wallerian degeneration has occurred. So you really want to wait till 7 days at least, because if you study them too early, you may get a motor response that would go away by day 7 if you studied them later. But you want to also study them before 2 to 3 months when reinnervation occurs, because you want to get an estimate of the CMAP size. The CMAP will be small if you've lost a lot of axons, but in incomplete injuries, as those axons begin to sprout, the compound muscle action potential will get bigger. And it gets bigger not because necessarily you've got more axons growing, but it's because the existing axons have increased their motor unit territory. So it becomes misleading if you wait too long to study your CMAP. So someplace in this range is probably the ideal, between 1 week and that 2 to 3 month range. Now this has been studied fairly well in the face, and I should say that the face and the limbs are somewhat different in how we use the EMG to establish prognosis. But in the face, it's been a lot, both in the EMG literature as well as in the otolaryngology literature, that you measure the motor response, the compound muscle action potential on the involved side, and compare that to the other side. If your abnormal side is at least 30% of the good side, so if you have 1 millivolt on the good side and 300 microvolts or more on the bad side, that's almost always a really good outcome. And that makes sense, 30%. You probably only need about 30% of axons in general to give you normal strength. And the reason for that is each axon can take on some place in the range of 5 to 7 times its original motor unit territory, a number of muscle fibers. And as that sprouts, it can reinnervate most or all of the denervated muscle fibers. So that's a good outcome. If you have less than 10% of the other side, so we have lost more than 90% of the motor axons, that's generally a poor outcome. And as we mentioned before, sometimes that can be poor due to weakness, and sometimes it can be due to the synkinesis that happens. And if you're in that in-between range, 10 to 30%, you'll often get a good outcome, but not always complete recovery. So these are the numbers you want to keep in mind as you do your motor studies. Fibrillations don't really tell you much about prognosis. You would think that they would, but the fibrillations just don't help you with prognosis in most things. And that's because you don't need to lose many axons to get some fibrillations. And it's also an ordinal scale. So we measure it from 1+ to 2+, 3+, 4+. And we know that 2+ is more axon loss than 1+. But we don't know how much more. It could be 5% more, it could be 5 times as much. We don't really know, we just know it's more. So it's not really a quantitative scale in that way. Another thing to remember as you're doing your electrodiagnosis is that except for the facial, the injuries that are right in the face area, we're pretty much always distal to the lesion site. So the temporal bone fractures, the Bell's palsy, the acoustic neuromas, all those kinds of things, we're stimulating and recording all distal to the lesion site. So that means that if we can't get proximal to it, we're not going to see conduction block. We're not going to see focal slowing. And so those you won't look for. And the latency really doesn't make much difference in those kinds of injuries. But what we do see is that the compound muscle action potential size, the motor response, in those cases, because we're all distal, the size is proportional to the number of motor axons. So if your CMAP is about 30% compared to the other side, you probably have about 30% of the motor axons, as we said on the previous slide. So let's just talk about the facial nerve studies. This is, this is how we do the facial nerve studies. We stimulate the nerve at the stylomastoid foramen, and it's not hard to do. You can take your stimulator and you sort of straddle that sternocleidomastoid muscle. So your cathode is in front, just below the ear, the anode is in back, and that's a nice, easy way to stimulate the nerve right there below the ear. So stimulation is not too hard. And then the recording, this takes some thought. And so if you're thinking that you want to just have a general sense of the facial nerve, or if you're doing repetitive stimulation studies, you could just record from nasalis. That would be fine. If you are worried more about a zygomatic branch, or you want to get a couple of channels in there, you could also record from orbicularis oculi. And then in some cases, depending on where the injury might be, is you can record from orbicularis oris down here. So if you have an injury to one of these branches, then you start thinking, I might want to record from multiple muscles, either at the same time or individually. Whereas if the lesion is truly proximal acoustic neuroma, probably one is fairly representative of the others. So think about your recording site according to the patient, and not all of these muscles will be equally affected. Your current is generally in that 20 to 50 milliamp range, assuming a 0.1 to 0.2 millisecond stimulus duration. You don't want to go too high than that. And why don't you want to go too high? Because if you stimulate really high over here, look at who's right next there. That's the masseter muscle. And remember what the masseter is supplied by. Masseter is a muscle of mastication, so that's cranial nerve 5. And I'll show you some recordings later on. But if you stimulate high enough, you'll get the masseter to contract, and that'll give you a little bit of a CMAP. How do you know you've done that? Well, there's a few things. One is you only see the response with high levels of stimulation. Second is that if you're looking at the patient, and it's good to look at the patient when you're pushing the stimulator button rather than the screen, but you look at the patient, you see the sudden jaw closure. And the third thing is that the latency is too short to represent the nasalis or orbicularis oris or whatever you're recording from out here. It's only 1 or 2 milliseconds, and that's too short to really be a facial nerve. So those are the hints: the high level of stimulation, the visible contraction, and the latency being too short. So keep your eye out for that, especially when you're going to higher levels of stimulation. It is helpful sometimes to do facial EMG, facial muscle EMG. The frontalis is a good one to represent the temporal branch. Orbicularis oculi is not bad for the zygomatic branch. Orbicularis oris is not too hard to do. Mentalis is not a bad one, but you do have to, and this is for the marginal mandibular branch, the mentalis, just be aware that crossed innervation can happen. So if you have a left-sided facial nerve injury, you might get some reinnervation of the mentalis from the right side. So another option is the depressor anguli oris. That's another way to go. Same branch, same marginal mandibular branch, but it's not as likely to get that crossed innervation from the other side. So keep these in mind. I must say, until I used to do these more commonly, I was always nervous about sticking a needle in the face, and I'd pull up the web and try to find where the muscles were, or a book. But after a while, you get used to these and finding these muscles. It's often good also to palpate the muscle on the normal side to make sure you know where it is. Now, sometimes you are interested in cranial nerve 5, and in these cases, you might actually study temporalis or the masseter muscles. These can be studied directly as well. And there are, as I'm sure you remember, 4 muscles of mastication. Temporalis and masseter are 2. And then you have your medial and lateral pterygoid. Those are a little tougher to get to, but they can be accessed, and it is useful to be able to access those for Botox injections if you have trismus or tight closure of the mouth. Another study you have in your possible toolbox is the blink reflex. So the blink reflex, what we do here is we stimulate the supraorbital nerve, which is a part of the 5th trigeminal nerve. It's just right at the supraorbital notch there. We record from orbicularis oculi. And it's a way to activate the facial nerve proximal to the bony canal and proximal to the site of the potential injury if it's in the bony canal. And also because we're stimulating the supraorbital nerve, we're evaluating the first branch of the trigeminal, or V1. And as we said before, EMG of the masseter or temporalis can be used to evaluate V3. All the muscles of mastication are from the 3rd branch of the trigeminal, or from V3. So this looks like a complicated diagram, but I'll just go through it slowly. So what we do is we stimulate the supraorbital nerve at the supraorbital notch, and that comes in through 5, through the 5th trigeminal nerve, in through the nucleus. And it takes 2 pathways. So right here is the little branch point. It can go through what we'll call the R1 pathway, right through the pons to the ipsilateral 7. So it comes from 5 just to the ipsilateral 7, and then goes back out. And that's a short, just a few synapses pathway. And that R1 is what we see here on the ipsilateral recording. We see that takes around 12 milliseconds or so. You get this consistent R1 response here. And that's just ipsilateral. If you record on the other side, you don't see anything in R1. The other pathway it takes is it goes down, all the way down into the medulla and even the spinal cord. This is the R2 pathway. And then that's a polysynaptic pathway that goes both sides. So both to the ipsilateral and to the contralateral 7. So for the R2, and this takes in the range of 35 milliseconds, we'll record from the orbicularis oculi both sides. So this is R2 on the ipsilateral side. We saw the R1 around 12 milliseconds, the R2 around 35 milliseconds. And then on the other side, we just see the R2. This is the R2 over here, around 35 milliseconds. There are normal values, obviously, for the onsets as well as for the side-to-side comparison. Be aware that the R1 is fairly consistent, not perfectly. The R2 is much more variable, though, because it's a polysynaptic pathway, and you really have to do multiple ones to find the earliest one. So you can think through, based on this diagram, what should be normal or abnormal in the blink reflex based on where your nerve injury is. So if you have a trigeminal nerve injury and you record from the ipsilateral R1, you get nothing there because you get no input. In fact, you get nothing from the R2 or nothing from the contralateral R2 because nothing's coming in. So you'd see nothing from that stimulation of the involved side if you had a trigeminal nerve lesion. The other side would be fine, but the involved side, you'd get no response on either muscle. If you had a pons injury, and that's where you get the pons over here, then your R1 would be affected. You wouldn't see an R1, but your R2 could be okay. So it would only be an R1 effect. If you had a problem in the medulla, then that's where your R2s get affected on both sides. So you'd see R1 looks good, but you don't have any R2. And then if you had a facial nerve injury, which is the most common of all these things, then on the involved side, you'd be missing the R1 and missing the R2, both on the involved side. The other side would be fine, but the involved side, you'd never record anything. So you can think through each of these lesion sites and come up with what the blink reflex should show. Now, I do want to mention some of the role of EMG in helping our plastic surgery colleagues and helping patients with facial nerve injuries. And there is some fairly new advances in facial reanimation surgery. So there's a couple of things they do, and it sounds almost magical or unrealistic, but it does work for a number of people. One thing they can do is they can say, you know what, my masseter is working on this side, and I got other muscles of mastication that can help me chew. I got temporalis, I got my pterygoids, all that stuff. I'm just going to take a branch from masseter and use that to plug into the facial nerve. And what happens is that people will learn that in order to get a nice smile on this side, they have to bite down. So they'll say, okay, now just bite and smile at the same time, and you'll get a more symmetrical smile. And it does help cosmetically. And that works pretty well. You don't have a long distance to go. You don't really miss the masseter muscle too much, and that works fairly well. Another option, which doesn't work quite as well, but often does work, is you can take a small branch from the good side, use a nerve graft, like a sural nerve graft, you tunnel it under the skin here, and you bring it to the bad side. So it's a small branch that was supplying orbicularis oculi on this side. You still got other branches supplying orbicularis oculi, and you just tunnel it through and supply it on this side. They can also go across the top of the face here. It's not shown on this diagram. And they can also do the same thing in the lower branches down below the lip. And there's not a big scar. It's just a little scar here and a little scar over there where they do the anastomoses. But that can give you more symmetry. It won't give you a perfect result or a normal result. But what it does do is it gives you a little more symmetry. So when you smile on one side or move your mouth on one side, the other side moves to some extent as well. And we can help our surgical colleagues with this planning, with the surgical planning, as I'll show you in a bit. So this is an example case. And by the way, I just have a few more slides, 2 cases to show you. So if you have questions, please put them in the Q&A box or in the chat, and I'll come to them in just a few minutes. This is a guy, 29-year-old guy, a software engineer kind of guy, who had, he noticed that he had a lump under his chin here, which turned out to be a submandibular gland tumor. In the end, it turned out to be benign, but he got it removed, as I would too if I got some tumor that I don't know what it is. So he got that out about 8 months ago. And he has a weak depressor anguli oris. In other words, when he opens his mouth, the one side of the lip doesn't come down because he has no, his marginal mandibular branch, which was going near the tumor, was affected. And so he has a weak depressor anguli oris on that side. So he came to the lab because our surgeon was wondering, is there something she should do for this depressor anguli oris? Should she explore the nerve? Should she maybe do a nerve transfer where she would take a branch to the platysma and plug that into the marginal mandibular branch and give him better function? So we did our standard nerve conduction studies. This was on the left side, was the involved side. And as expected, when you record from nasalis, orbicularis oculi, absolutely beautiful responses. These are symmetrical. This is the left nasalis, left orbicularis oculi, right nasalis, right orbicularis oculi. Everything's great here. And of course, it's going to be great because we're not recording from that one affected branch, the marginal mandibular branch. And then we did our blink reflex too, which again, is kind of a routine thing that our techs do, but we didn't really need to do it in this case. So this is the left side. Here's an R1. It's not a great R1, but it's there. This is, and then you have an R2, and this is the contralateral side, the R2. And then this is the other side. You have an R1 with ipsilateral stimulation, R2, and then the contralateral R2. So the blinks, they're all fine. They're all in good shape. So here's the needle in the involved muscle, the mentalis. Now he's 8 months out, and we see these motor units. I tried to do a video recording, but I couldn't get it to work between the PC and the Mac. But this is the important thing. So what do you think about this motor unit? This is a single motor unit. That's all he had going in mentalis. Look how polyphasic it is. And it's not even stable. You can see different firings of the motor unit on the bottom here. They look a little different each time. So this is one reinnervating motor unit. You can see a positive wave here too. So I don't really know what to make out of that. And so the thing I did is I looked back. He had a prior EMG from the local hospital where he got this done. And you know what? At 1 month and 3 months, he had one motor unit firing. Probably the same motor unit. He's now 8 months out. He's got one motor unit still. So I'm trying to think, well, is this guy going to get any better? I don't think so. A lot of it's the timing. It's the 8 months. It's the prior EMGs. He's probably going to have this one motor unit trying to struggle to make it there for forever. I don't think it means that he's going to grow more. If we saw this just at 1 month and we didn't have any later ones, I'd say, oh, it's maybe hopeful because he's got some intact innervation. So I don't think his mentalis, his marginal mandibular branch is going to do well. And then the question was, well, should we transfer platysma? And platysma, this guy had a hard time activating it. It was also not too far from the surgical site. And so the question was, should we just take a branch from platysma? And what do these motor units look like? These are reinnervating motor units too. Here's more on the trigger and delay line in the bottom. So is this platysma normal? I don't think so. That also had an injury. That's also reinnervating, and it's not in great shape. And the general rule of thumb is that if you're going to do a nerve transfer, the donor nerve, the one you're taking from, should be pretty normal. If you transfer an abnormal nerve, it's not a great way to proceed. You're not going to get a great outcome. So, excuse me, I just saw this patient recently. I think what she's going to do is not transfer the platysma because we don't have a normal platysma, but instead just explore the nerve and see if there's anything that's pressing on it or that's causing the patient to not do well. And here's one other case I just wanted to show you briefly, and then we'll go to summary and questions. This is a guy who had a brainstem meningioma 9 months ago. So this was a big meningioma. It wasn't an acoustic neuroma. It was more at the pontomedullary junction. And he had a complete facial neuropathy on that left side. So here's his facial nerve recording from nasalis, recording from orbicularis oculi, and then here it is on the other side, nasalis and orbicularis oculi. One thing I want to mention is that we saw this little peak right here. This is the masseter. This is when we go up high enough stimulation. You can see it's kind of an early response, and it's only with high levels. You can't see that from this diagram, but it's only with higher levels of stimulation. So we ignore this one, and I believe this was no response on the left side. So this is the guy where they were thinking about taking that masseter, the masseter transfer, and plugging that in. But you want to make sure the masseter's okay. Here's the EMG of the masseter. What's that? That's a fibrillation potential, positive sharp waves. And that's what we saw. It was multiple fibrillations, positive sharp waves, some reinnervating motor units. And I think I have some more pictures here. There's some early reinnervating motor units that are happening. And then this one motor unit is firing kind of fast. He's going about 20 hertz here. We got these reinnervated polyphasic motor units. So my advice to her was, gee, I don't know. We don't have a normal muscle in masseter, and it's hard to appreciate clinically. Don't think that's a great option. So I think she's going to just hang tight on that and do the cross-face facial reanimation that I showed you about. So I'm going to just wrap up here and go to questions. So take-home points: know your facial nerve anatomy. It's always good to have that down. You won't remember necessarily every single muscle in the face, but it's good to have some representative muscles you can record from. Be sure if you have a partial injury to record from the affected muscles, whether you're doing nerve conductions or EMG. That's really important to not just record from unaffected muscles. If you're thinking about prognosis, your CMAP amplitude is the most important thing. CMAP amplitude. If you're 30% or more of the other side, then that's a good outcome. Less than 10% is a bad outcome, and that 10 to 30% is intermediate. Fibrillations, again, really don't make a call in terms of prognosis. Synkinesis is an issue, so it's not just weakness that we worry about, it's also synkinesis. I would say develop strong ties with a surgeon if you see many of these. You need a surgeon who's good with facial nerve, with reanastomosis, facial reanimation. And I must say that I've learned a lot by working with our plastic surgeons who do this. And now I used to just think about prognosis and how is the muscle affected. Now I'm starting to think, okay, she's going to want to take the masseter branch and plug that in, or the platysma branch and plug that in. I better go check that donor muscle to see if that's okay, because that's what she's going to ask next. So you want someone who's going to be good at handling this. And I do hope to see you in person someday. And thank you for having me to Cairo. It was a quick flight, and I'm really glad to be there. I will now try to move to questions if I can.
You heard me now?
Yeah, now I hear you. Yeah, perfect. Perfect.
I want to thank you about your appreciated time and your valuable time and this amazing talk. So we have a lot of questions about this topic. First, in plastic surgery here in Egypt, some needs to examine each branches of the facial nerve and compare for the sound site to decide what about the interventions to do with the main severe branch. Is it acceptable electrodiagnostically? Yeah.
To compare to the other side?
Yeah. I mean, in plastic surgery, he want me to do temporal branch recording from orbicularis oculi, and also the zygomatic to recording from the nasalis, also the buccal from the orbicularis. Yeah. Different branches and compare, not one branch. What about the interventions?
Yeah, and I think that's a really good point. And a lot of that is, I actually like doing both sides at the same time because there's so much variability. And you've probably seen this before. The CMAP can be 300 microvolts in some people, like the one I showed you was 2.5 millivolts. And so you want that side-to-side comparison also, just so that you're sort of symmetrical where you place the electrodes. So I think that is a good approach to record from whatever muscles the surgeon is asking about, because it depends what they have in mind, which muscle they want to use both as donor and as recipient.
So what about the prognostic value? What about the measures of the prognosis after 2 months of the therapy, such as physical rehab or some remedies? How to decide what about the severity after 1 or 2 months?
Yeah, I think in that 2-month range, you know, the main thing is the CMAP amplitude. And you could, like you said in your first question, record from different muscles, because the prognosis for some muscles may be better than other muscles. So if some muscles, say the frontalis has a big CMAP, but your auricularis oris has a small one, you're more likely to get recovery in the frontalis. But it's in that 2 to 3 month range. Once you wait a year, for example, you already know what the outcome's going to be. It's going to be about the same as it is now at 1 year out. So in that few month range is when I would look. The other thing I should mention is that in complete injuries, and I'm sure you know this too, the plastic surgeons like to intervene early.
Yeah.
Because the earlier you intervene, the better the outcome, before the muscle becomes fibrotic and no longer open to reanimation.
Yeah, we have here in the question box a lot of questions.
Yeah.
First, I think you see it. Yeah.
Yeah. Should I just go through them? Is that okay? Or
okay, the first one is the compound muscle action potential is so small. So how can we compare it with the sound side? It is precise to be a 30% or 10 to 30. So it is good response,
yeah.
bad response.
Yeah. So this is it's not always easy to make that comparison, but we'll do the best we can. If we're generally, the good side might be a few hundred microvolts, 300 to 500 microvolts. So it's true. If you see 30 microvolts, is that absent or is that just a small response? It's a hard one to say. But the general rule is that's what I'm aiming for. That's my goal, is to say, is it more than 30%? And 30 is not a magic number. If you look at the different studies, some people choose 25%, some 35%. But in that 30% range, or is it less than 10% or absent? It's hard to know when something is truly absent, because you always get, you know, a little bit of noise in the baseline. You see something that might be you might see something that might be masseter or something like that.
Okay. Second one, is there any prognosticate values for bilateral facial neuropathy? I don't see any bilateral facial neuropathy other accompanied with peripheral neuropathy.
Yeah, yeah. So of course, with something like Guillain-Barré or AIDP, you could have bilateral facial neuropathy, and occasionally with Bell's palsy, but not so commonly. So whenever you have, at least what I find, whenever I do a bilateral, or I have a bilateral problem, I'll compare it with a lower limit of normal from the textbook. So I'd look at, well, what's the lower limit of normal? Let me just see what we got here. And I'd say, okay, if the lower limit of normal is 200 microvolts, that's the number I'll use. I don't have it in here. But I would use the lower limit of normal as my comparison number.
Okay. Can we use an intercostal nerve transplant? Intercostal nerve.
Ooh, maybe you could, but I have to say that they're not ideal. I've seen intercostal nerve stuff done, and it's a long way to go. It's a long way to go, and it does. The results that I've seen in just small numbers have not been ideal.
Okay. He also just one question: which is the best muscle for exam in needle EMG?
Oh, I think it's really depending on what your question is. So I think I'm pretty comfortable using most of the muscles in the face, and it depends. Like in your first question, you know, about the different branches. I think you might actually want to evaluate the different branches. So I'm pretty comfortable with frontalis, pretty comfortable with the orbicularis oculi, orbicularis oris, depressor anguli oris. So my goal would be, if you're not doing these every day, develop a comfort with one muscle from each of the major branches. Remember the temporal zygomatic, buccal, mandibular, and occipital. Develop a comfort with at least one muscle from each branch so you can study the representative branches. And that's what I would do.
Okay, to save your time, I want to ask you, what about the traumatic facial? I said here in Egypt, in my office, stabbing injury here in the stylomastoid foramen for the facial nerve. So the schedule here in Qasr Al Aini, it must to do a pre this site of the injury stimulation and post to execute any conduction block or axonopathy. Okay, yeah?
Yeah, so if you could look for conduction block. And you'd want to wait at least 7 days for the distal CMAP to disappear. So I think to do that study, wait at least 7 days. But you could look proximal and distal. Now, if you get no response, either proximal or distal, it could be axonotmesis or it could be neurotmesis. You don't know. So the nerve could be cut with the injury, in which case you'd want to do the repair right away. Or maybe it's just crushed and maybe there is capacity for axonal regrowth. And those are the tough ones. When you don't know, like a sharp laceration, you know you got to go in and fix it right away. But those blunt trauma, it could just be a crushing nerve injury. And that's where I think in our hands, we would typically look at them repeatedly over time to follow it. Okay, today, let's see what we got. Let's look again in 2 or 3 months. If there's any recovery, if there's no recovery, then by 6 months, they're going to want to go in and repair the nerve, explore and maybe repair the nerve.
After first 7 days, you prefer to admit plank reflex with the routine CMAP or not?
Sorry, plan to do the...
After we can start the electrodiagnosis compound muscle action potential after 7 days of the insult. Can we admit plank reflex also?
Oh, blink reflex. Oh, yeah. So that's a really good question. So the 7 days for the routine facial motor studies, we're waiting for the response to the axons to die off while they're in degeneration. So the response will get smaller as time goes on. So if they call me at day 4 or day 5, I say, you know what, I got to go get my hair cut. I got to go get lunch. I don't have time today. Wait till 7 days. I make up some excuse to get into 7 days. But you're right, the blink reflex is different because in the routine facial motors, we're both stimulating and recording distal to the lesion. So to see a change, we're waiting for those axons to die off. In the blink reflex, we're stimulating proximal to the lesion site. So the blink reflex should change right away. Blink reflex should change right away. Now, so you can pick up abnormalities right away. Of course, if you get no response with the blink reflex, you don't know, is that demyelination and conduction block or neuropraxia, or is that complete axon loss? Because either one would give you absence of a response. So the blink reflex could tell you, yes, there is a lesion there, but it won't help you sort out prognosis or whether it's axon loss or demyelination. The CMAP amplitude would be better at the prognosis.
Okay, I think this is the last one. Can you use somatosensory evoked potential in peripheral facial paralysis?
Not that I know of. I know you can certainly do trigeminal SEPs, and you get a big, somatosensory response from that. I'm not sure that the facial nerve has enough sensory. I know it does have some, but it doesn't have a huge representation in the somatosensory cortex. So I don't think that it's that useful.
Excellent. Thank you, dear Professor Larry Robinson, one of the best I listened for your talk ever. Hoping to visit Egypt soon after this crisis disappears. Again and again, I appreciate your time and thank you. Goodbye.
Okay, thank you for having me. I hope I get to visit in person sometime. Great questions that your folks had too. It shows you're quite have advanced electromyographers there.
Yeah, thank you. Okay, bye.
Okay, bye-bye now.